I should start, right? Good afternoon. We are going to start our next session, which is titled Untangling the Mysteries of Autoimmune Pancreatitis. I'm Dhiraj Yadav from the University of Pittsburgh Medical Center. And my co-moderator is Dr. Roopjyoti Talukdar from the Asian Institute of Gastroenterology. We have 5 talks in this session. We'll request the speakers to keep their remarks to about 13 minutes so that we can have about 10 minutes for discussion at the end. We'll ask the speakers to go back to their seats and we'll have everybody come back up after all the talks. With that, I'll ask Dr. Talukdar to introduce our first speaker.
Hi, good afternoon. Let me call upon the first speaker, Dr. Kazushige Ushida from Kochi Medical School, Kochi University. And he'll be speaking to us on the historical perspectives of AIP and IgG4 related disease. Dr. Uchida, please.
Yeah, I'd like to thank the chairperson and the organizing committee of this meeting. It's a great honor to be able to present here. My name is Kazushige Uchida. I'm from Kochi University, Japan. Yes, no response. Oh. Out back.
Could you please reset the clock?
I have no conflict of interest. This slide summarizes the history of autoimmune pancreatitis and IgG4 related disease from perspective of Japanese researcher. The first case report of AIP was published by Dr. Searles in 1961. However, pancreatitis due to immunological disorder was doubtful because there is no lymphoid organ in the pancreas. In 1991, Dr. Kawaguchi proposed a prototype of pathological characters of type 1 AIP. And in 1996, Dr. Yoshida advocated the disease concept of autoimmune pancreatitis. Subsequently, Dr. Hamano published the importance of high serum IgG4 levels in this disease. In 2003, Dr. Kamisawa stated that this disease may be systemic disease. In the same year, Dr. Notohara proposed clinical features of type 2 AIP originated from idiopathic duct-centric chronic pancreatitis. Coming back to 2002, Japan Pancreas Society proposed diagnostic criteria for the first time. In 2003, Professor Furloni proposed Italian diagnostic criteria. In 2006, Professor Charlie, Mayo criteria. Professor Kim proposed a Korean diagnostic criteria. Japan Pancreas Society revised Japanese diagnostic criteria. Asian diagnostic criteria was proposed by Japanese and Korean researchers in 2008. Two problems were noted before ICDC. First is diagnostic method varied by countries. Second challenge was dealing with idiopathic duct chronic pancreatitis. And Professor Shimosegawa and Professor Charlie played a key role in establishing ICDC. Japan Pancreas Society proposed revised diagnostic criteria in 2018 and consensus guideline in 2020. Next, I present the history of IgG4-related disease. It is thought that the IgG4-RD was first mentioned in the report of Mikulicz disease. However, Mikulicz disease was hushed up because it was considered a subtype of Sjögren syndrome. In 2006, Dr. Kamisawa proposed IgG4-related sclerotic disease based on type 1 AIP. Dr. Yamamoto proposed IgG4-related plasmacytic disease based on Mikulicz disease. In 2008, Professor Masaki termed IgG4 MOLPS based on lymph proliferation. As various names were assigned to the same disease, Japanese research group unified the disease name as IgG4-related disease in 2011. In the same year, Professor Stone held the first international symposium at Boston. This is a group photo of the first international symposium on IgG4-RD. Unified name IgG4-RD and related pathological criteria was proposed here. Final diagnosis for IgG4-RD, which were initially started in 2011 at first international symposium, and the ACR-EULA classification criteria in 2020. From here, I will talk about the diagnosis of AIP. The Japanese clinical diagnosis criteria 2018 were revised based on ICDC. These criteria are for only type 1 AIP because type 2 AIP is rare in Japan. These criteria are constructed as 6 major diagnostic items. Here we have presented the result of multi-center study conducted by our Japanese AIP studying group. We recruited 1,606 patients with type 1 AIP and 42 patients with type 2 AIP. Overall, 94.7% patients were diagnosed with type 1 AIP by JPS 2018. Further, 93% patients were diagnosed with type 1 AIP by ICDC. However, all 42 patients were diagnosed as type 2 AIP by only ICDC. Recent progress of FNB nitro is remarkable. However, the issue of small sampling specimens continue to exist. As you know, neutrophils are important for diagnosis of type 2 AIP. We previously investigated the neutrophil infiltration in alcoholic chronic pancreatitis, type 1 AIP, and type 2 AIP. Around the interlobular pancreatic duct, the proportion of infiltrated neutrophil was significantly higher in type 2 AIP than in type 1 AIP and alcoholic chronic pancreatitis. In contrast, around the intralobular pancreatic duct, there was no significant difference among three groups. Furthermore, we observed gels. In the case of type 1 AIP, gel was observed. These results demonstrate that diagnosis of AIP, even via FNB, may be difficult. Next, we discuss treatment. This slide shows the first-line therapy for type 1 AIP in Japan and United States and European countries. As you know, we performed maintenance therapy for 3 years. Maintenance therapy is not performed in United States and European countries. Professor Masamune reported the usefulness of maintenance therapy for type 1 AIP. Of course, there are patients who relapse even after receiving maintenance therapy. However, there may exist patients who do not require maintenance therapy. A new search for a biomarker is necessary. Finally, we will discuss the pathophysiology of IgG4-RD, include type 1 AIP. It is hypothesized that multiple pathogenic factors are involved in the development of this disease. These include genetic factors, environmental factors, innate immunity, and acquired immunity. These factors are associated with development, relapse, and progression of this disease. Genetic factors include their disease susceptibility gene. Regarding environment factor, we reported hypermethylation of MST1. Regarding innate immunity, based on our data, TL signaling, M2 macrophage, basophil, and neutrophil are involved in the pathophysiology of this disease. Regarding acquired immunity, regulatory T cell, regulatory B cell, and plasmacytoid TC are also involved in this disease. This slide shows our hypothesis of pathophysiology of IgG4-RD based on our data. Various immune reactions via innate immunity and acquired immunity participate in this disease. However, the immune cell that directly linked to treatment is a B cell. In particular, plasmablasts play an important role in this disease. Furthermore, plasmablasts participate in fibrosis. Yesterday, Professor Okazaki presented data regarding clinical trial of inebilizumab. Besides various other clinical trials of agents targeting B cell and plasma cell are ongoing. Here we will discuss the remaining problem of type 1 AIP and IgG4-RD. First issue is handling of atypical cases, such as focal swelling of pancreas and normal levels of IgG4. Of course, we can obtain larger tissue samples with the advancement of FNB needle. However, we cannot achieve a complete diagnosis of AIP frequently. Second issue is the exploration of biomarkers based on the pathophysiology of IgG4-RD. If this problem is solved, we can select the cases that need maintenance therapy. Finally, it is necessary to develop a new therapy as substitute for steroids. This is the final slide. I'll present my colleague for current presentation. Professor Kazuichi Okazaki, he was received the award last night. He is my mentor. I am grateful to him. Thank you for attention.
Thank you, Dr. Uchida. Our next speaker is Dr. Suresh Chari, who's a professor of medicine at the University of Texas MD Anderson Cancer Center. As you all know, he has made a lot of seminal observations in patients with autoimmune pancreatitis, defining the disease, criteria for diagnosis, and also therapy. He's going to talk to us about differential diagnosis of autoimmune pancreatitis and IgG4 related cholangitis.
Thanks, Dheeraj. Appreciate the opportunity to speak today. I have a couple of disclosures here. So the challenges of diagnosis of AIP include the fact that it is rare. It mimics other diseases, especially cancers of other organs. There's no single diagnostic feature, and the stakes of misdiagnosis are high. You can do surgery for benign disease. You can immunosuppress somebody who doesn't need it. Like I got an email yesterday, somebody from France who wants a second opinion because she's being prescribed rituximab for recurrent, what looks like idiopathic recurrent pancreatitis. You can immunosuppress patients with pancreatic cancer. I've seen that. And of course, you can delay the diagnosis of cancer, both in pancreas and other organs. So the stakes are high, and getting the diagnosis right is very important. The diagnosis, unfortunately, is not made by a single feature, and it's like a jigsaw puzzle, and the pieces need to fit. Unfortunately, these pieces are found in other diseases as well. So can you look at the stripes and say this is a zebra, or can you look at the tail and say it's a horse? It's really putting all the pieces together that make you acutely aware of the difficulty in the diagnosis and how you can be misled by the features that may be of another disease but seen in AIP. So the question is, how do you recognize a zebra among horses? But first things first, important to familiarize oneself with AIP, IG4SC, before you can understand the mimics. And the eye doesn't see what the mind doesn't know. So you got to know your disease before you can tell it apart from another disease. So I'll go through the differential diagnosis based on imaging, serology, other organ involvement, histology, and response to steroids. The clinical differential diagnosis is very difficult. We have looked at AIP and pancreatic cancer, and almost every feature seen in pancreatic cancer is also seen in AIP. There are some distinguishing features, like narcotic requiring pain is not a feature of AIP. And the other, obviously, if you have wide metastasis, it's not. And severe anorexia and profound weight loss are not features of AIP, but many features are overlapping enough to be confusing. So the differential diagnosis based on imaging varies by clinical presentation, stage of disease, and individual features. So it can vary by stage of disease. When it presents acutely, there is a differential. When there's a relapse, there's a differential. When you have burnt out disease, there's a differential. And so one needs to be aware that when you're seeing the patient, you may not be seeing the patient at their first presentation. You may be seeing them 3 years later, and you need to be aware of that. Sometimes the original presentation, even the patient is not aware of it. And I just saw a patient recently who had a resection for what they said was Allison tumor. And I went back and looked at the pathology, and it was not an Allison tumor. It was AIP. So patient may not be aware that they had a previous episode that was part of IgG4 related disease. So it can look like pancreatic cancer. It can look like regular pancreatitis. The relapse can look like pancreatic cancer. The relapse can look like cholangiocarcinoma. So I have had patients that I've treated with steroids, and the relapse comes back, and the surgeon says, I don't know what you did last time, but the patient has cholangiocarcinoma. I'm like, no, he doesn't. And you give him steroids, and the cholangio disappears. So it's very difficult. The relapse looks just like cancer as well. And bone type disease, you can get steatorrhea, you can get calcific pancreatitis, you can get a pseudocyst. I just recently saw a patient with pseudocyst and dilated duct and calcification. I give steroids, and the whole thing disappeared. The pseudocyst and the ductal obstruction. So the differential is pretty challenging in terms of what it can mimic. And nearly all pancreatic diseases are mimicked by this disease. Pancreatic cancer, both resectable and unresectable, acute pancreatitis, chronic pancreatitis, calcific, non-calcific, with pseudocyst, steatorrhea. There's nothing off the table, and when you look at AIP, and that brings the problem of over suspecting it can lead to overdiagnosis. So you need to know how to put the pieces together. And the pancreatic morphology, you have a very typical presentation with a sausage-shaped pancreas. You can have focal enlargement. And of course, there's lots of atypical manifestations: low density mass, dilated duct, peripancreatic involvement, extensive calcification, pseudocyst. So it's problematic in the sense that because of this wide differential, it can be over suspected in patients who don't have it. So this is a group 1, which I call a highly suggestive of AIP. The top one is the one which is most dramatic in terms of having a capsule-like rim as well as a sausage-shaped pancreas. And so this is the very typical presentation of AIP. Then you can get focal enlargement, and it's a plump pancreas, but so this is where the mistakes are made. You have a plump pancreas in a young woman, and you measure IgG4 because they have abdominal pain, and that's elevated, and now all of a sudden a normal pancreas is labeled as autoimmune pancreatitis. So very easy to make that call. Pancreas large but enhances normally, patient often young women. This is the indeterminate group where there is a focal enlargement but not a low density mass, and the rest of the pancreas looks okay. So again, atypical. And finally, this is low density mass with a dilated duct or even peripancreatic involvement. Randy would know that the second patient is the first patient with steroids we treated at Mayo. And these patients look like cancer. Even today, if you show me this, I'll tell you this cancer, but it was not. So, and then you can see calcifications, you can see atrophy. So the differential is wide, and you have to be aware of the differential, but at the same time, not overreact to every patient that you're seeing as having it. Serology is the other one. When I started this way back when, I still remember a talk where I told people that if you have IgG4 elevation, you have the diagnosis, and I should take that back. That was awful. Now I know that vast majority of patients with IgG4 elevation will not have AIP. So we looked at 500 pancreatic cancers, 10% of them had elevated AIP. 25% of AIP have normal IgG4. And before measuring IgG4, know how you're going to interpret it. This is the most important thing. Don't order it without knowing how you're going to interpret it. Otherwise, you'll be in bad shape. So useful, but not diagnostic biomarker. The higher the value, more than 2x, more than 4x, the higher the specificity, but lower sensitivity. Post-diagnosis, I don't use it very often, but many people use it, and they start treating the patient once the elevation of IgG4 occurs. Again, a mistake. You want to treat the disease, not the IgG4. The IgG4 will respond to steroids, they will respond to anything, but does the patient really need steroids or rituximab or whatever else you're giving? So on follow-up with no evidence of disease, I will not treat serologic relapse alone. It doesn't make any sense because it will come back. And so it's not a place to treat the patient. I use it only for diagnosis. Response to steroids is, the response is not equal to true response. This is very difficult for people to understand. What does it mean? There's non-specific causes of response. The moment the patient leaves my office, when I've told them they have autoimmune pancreatitis, they feel way better than when they came in. You already have a response before you even take steroids. So the relief from anxiety, the placebo effect is pretty dramatic. They can even improve their appetite and gain weight because now they know they don't have pancreatic cancer. It's mood elevating, the steroids themselves, appetite stimulating, and spontaneous improvement in pancreatitis due to pancreatic cancer can be attributed to steroids. So there are lots of places where you can get fooled. What you need to look for is objective improvement. Don't wait till after steroids are done to image the patient. So if you wait 12 weeks to image the patient, after you have tapered the steroids, you can actually see a recrudescence of the disease and feel patient has not responded to treatment. So I image them at 6 weeks to make sure they have had a response and then continue treatment and take them off treatment and if necessary, image them again. And there are enough issues here that's difficult to cover in this short talk. But the most common reason for concern for AIP-IgG4C is increased IgG4 positive cells on histology. Unfortunately, this is suggestive but not diagnostic. It's one of the features, but not by itself diagnostic. Both pancreatic cancer, cholangiocarcinoma, PSC, all have increased IgG4 positive cells in a subset of patients. FNA, I believe, is largely inadequate to diagnose AIP. It's good for excluding cancer, but to make a positive diagnosis of AIP, it can happen in a small subset of patients where a chunk of tissue is also obtained with the FNA, and maybe you can make it. I do not approve of ampullary and mucosal biopsies in general. By the time an ampullary biopsy is positive, you can see it on CT as well. So I've not found it very helpful. Storiform fibrosis needs an eye of a pathologist who knows what he's looking for, he or she's looking for. Obliterative phlebitis, much more specific, but not often commented upon because pathologists are not familiar with it. The differential diagnosis of the biliary involvement includes just about everything that you see in the biliary tree. Mimics pancreatic cancer when it's in the lower down, mimics cholangiocarcinoma in the middle, and mimics intrahepatic PSC in the intrahepatic region. So it pretty much resembles everything. So this is a AIP patient with distal bile duct involvement resembling pancreatic cancer. This is that patient with patient's pancreatic findings. This is a patient, Randy's first patient treated with steroids, a hilar cholangiocarcinoma, treated with steroids and goes away on steroids. So again, we have done blinded studies and radiologists cannot tell these apart. So these are pretty impressive. This is a patient I treated with steroids who came to the liver clinic for PSC and given steroids, everything disappeared. So it can resemble PSC almost to the T. And then this is a patient who has got a stricture in the distal bile duct. It's not going away after steroids. Does the patient have a relapse or is this a fibrotic bile duct that'll never get better? I think the latter. And so I use a liver test to make sure that I know they have a relapse and not a fixed stricture due to fibrosis. So as I said before, our studies looking at inter-observer agreement show poor inter-observer agreement with ability to tell these strictures apart by experienced radiologists and ERCPs. Misinterpreting steroid trial, as I said before, false positive, feeling of wellness on steroids, non-specific decrease in liver tests, associated pancreatitis. All this happens with steroids. Even in the biliary side, you'll see the same issues. We have shown that every form of biliary injury where there's liver test elevation and you give steroids, the liver tests improve, regardless of underlying etiology. So improvement in liver tests is not equal to response to steroids unless you know how to interpret it. So we can discuss more. So in summary, AIP and IgG4C can mimic nearly all the more common conditions, can be challenging to diagnose in all phases, initial, relapse, and burnt out disease. Gather as much information, give weightage to the evidence, and know how to use and interpret a steroid trial. I'll stop here. Thank you. Appreciate it.
Thank you, Professor Chari. Next, I'd like to call upon Dr. Tetsuya Takikawa. He's a assistant professor and research associate at the Department of Gastroenterology at Tohoku University. Dr. Takikawa, please go ahead.
Thank you for the introduction. I'm honored to be here and to share our work. I'd like to talk about the long-term prognosis of AIP, focusing on its association with malignancies based on a nationwide survey in Japan. I'm sorry. AIP is a rare form of pancreatitis with a hypothesized autoimmune mechanism. AIP is characterized by imaging findings such as focal or diffuse pancreatic enlargement and a good response to steroid treatment. Recently, the risk of malignancies in IgG4-RD patients has been attracting attention. In Japan, a nationwide survey was conducted, and this study showed higher risk of malignancies. The other studies also reported the high value of SIR, standard incidence ratio. So IgG4-RD may be at higher risk of malignancies. Limited to AIP, recent systematic review showed the prevalence of malignancies is 9.6%. I reviewed 5 studies that investigating the risk with general population. These studies showed high value of SIR, but sample number is relatively small. AIP might be at higher risk of malignancies, but a statistically reliable study with a large sample size is needed. As for pancreatic cancer, as far as I searched, there are only 2 reports that investigated the risk compared to general population. The high value of SIR was presented, but pancreatic cancer number is very small at 2 to 4 cases. So I think it remains unclear whether AIP is a risk factor for pancreatic cancer. Therefore, we have planned a large-scale epidemiological study on the relationship between AIP and malignancies. The aim of this study is to clarify the risk and clinical features of malignancies, including pancreatic cancer in patients with type 1 AIP. I'll show the following topics. First, the result of nationwide cohort study in Japan, focusing on the risk of malignancy and clinical features of pancreatic cancer. Second, I'll discuss mechanism of malignancy development. Let's begin with first topic. This study is a multi-center retrospective cohort study. Subjects were type 1 AIP patients aged 20 years or older, diagnosed between 2000 and 2020. In Japan, type 1 AIP accounting for majority of AIP. So this study included only type 1 and not included type 2. A total of 1,364 patients were enrolled. This table shows clinical features of enrolled patients. Malignancies were observed in 180 patients, and pancreatic cancer were observed in 19 patients, 1.4%. And 58 deaths were observed. 5, 10, and 50-year cumulative incidence rates of all malignancies were 10.2, 18.1, and 37.1%. The SIR was 1.21 with significant difference. As for pancreatic cancer, the SIR was 3.22, indicating a higher risk. This table presents the number and the SIR of all malignancies at all sites. The frequency was the following order: gastric cancer, lung cancer, colorectal cancer, prostate cancer, and pancreatic cancer. The SIR with significant difference were pancreatic cancer of 3.22, bladder cancer, malignant lymphoma, and bile duct cancer. This table shows time and SIR of malignancies from AIP diagnosis. Both all malignancies and pancreatic cancer showed significantly higher risk, less than 2 years and more than 5 years after AIP diagnosis. The risk of development of malignancies was high both in the short and long term after AIP diagnosis. We also investigated risk factor for malignancies. In addition to older age, the absence of maintenance therapy, MST, was identified. Short summary, type 1 AIP were at higher risk for malignancies, and the risk of pancreatic cancer was the highest. These risks were particularly high, less than 2 years and more than 5 years after AIP diagnosis. And the absence of MST was associated with the development of malignancies. The next topic. In this study, 58 deaths were observed, and the main cause of death was malignant disease. Among them, pancreatic cancer was the most common, observed in 9 cases. We investigated prognostic factors, older age, the absence of MST, development of pancreatic cancer, and the development of the other cancers were identified. And pancreatic cancer had the highest hazard ratio. These figures are the long-term prognosis according to pancreatic cancer development. 5-year OS rate without PC was good, say 98.3%. But with OS rate with PC was poor at 35.4%. This table presents clinical features of pancreatic cancer. 73.7% of patients was diagnosed at asymptomatic stage. Regarding clinical stage, stage 4 was the most common, but a total of 31.6% were stage 0 to 1. And about half of patients underwent surgical resection. Short summary, pancreatic cancer was the most leading cause of death and had a significant impact of prognosis. But 31.6% were stage 0 to 1, 47.4% underwent surgical resection, and the 5-year OS rate was 35.4%. According to National Epidemiological Survey in Japan, clinical stage 0 to 1 was 6.8%. Resection rate was 31. 5-year OS rate was 11.3%. Therefore, pancreatic cancer was the most of had major prognostic impact, but pancreatic cancer associated with type 1 AIP may have higher proportion of earlier stage and better prognosis compared to without type 1 AIP. I think this may be because the examination focus on pancreatitis routinely performed in AIP patients. Last topic. This study showed higher risk in short interval and long interval after AIP diagnosis. In the case of short interval, one possible reason is intensive screening. In Japan, at diagnosis of AIP, whole body CT, endoscopic sonography, upper lower endoscopy, and occasionally PET CT are performed. Another reason may be paraneoplastic syndrome. In the case of long interval, I consider chronic inflammation and long-term steroid use may be involved. Two studies from Japan that investigated the association time and AIP or IgG4-RD diagnosis. These studies also showed particularly higher risk within 1 year after diagnosis. These results suggest involvement of paraneoplastic syndrome. And chronic inflammation is known to be risk for carcinogenesis. For example, chronic pancreatitis is a major risk factor for pancreatic cancer, and the recent systemic review showed the very high value of SIR. And AIP can cause pancreatic stone, duct dilatation, and atrophy, similar condition to chronic pancreatitis. In addition, a study investigated AIP and chronic pancreatitis dissection specimens. Both specimens showed similar number of Pannin lesions, precancerous lesion of pancreatic cancer. These results suggest chronic inflammation may also contribute to carcinogenesis in type 1 AIP, as well as chronic pancreatitis. In this study, the patient who received MST showed better prognosis, and the absence of MST was a risk factor for malignancies. Similar results was shown from a nationwide survey of IgG4-related sclerosing cholangitis in Japan. Disease and inflammation control due to MST may contribute to suppression of malignancies, which lead to improved long-term prognosis. On the other hand, long-term steroid use is also known to the risk of malignancies. A Korean insurance database showed higher risk of malignancies in long-term steroid users. This mechanism is complex and not fully understood, but immune tolerance or microenvironment of tumor cells may be involved. But the association between long-term steroid use and malignancies need further study. I'd like to summarize our presentation. We clarified a higher risk of malignancies in type 1 AIP patients. Pancreatic cancer has the highest risk and was identified as a major prognostic factor. But the surveillance for type 1 AIP, considering the possibility of malignancies, especially pancreatic cancer, may contribute to improved long-term prognosis. The mechanism underlying the increased risk of malignancies has not been clarified. I'd like to my sincere gratitude to all collaborators. Thank you for your attention.
Thank you, Dr. Kakikawa. Our next speaker is Dr. Phil Hart, who's a professor of medicine in the Division of Gastroenterology at Ohio State University Wexner Medical Center. Dr. Hart is also the co-chair of the Diabetes Working Group of the CPDPC Consortium and co-lead of the DREAM study for the type 1 diabetes in acute pancreatitis consortium. His work on autoimmune pancreatitis has included a description of long-term outcomes in patients with AIP, and he's going to talk to us about management of type 1 AIP, when to use non-steroid treatment.
Thanks for the introduction. I'm glad to be here. Thanks everybody for stopping by the session on your way to the beach. I do have some disclosures, and I'd like to echo a sentiment that Robert Sutton shared before he presented the preliminary results from CARPO, and acknowledge that this field has been, as Dr. Uchida really nicely laid out, has slowly developed over decades. But we've really plateaued, or we've reached some stagnancy. And I think industry and academic partnerships are really going to be necessary to move the field forward. So the next few talks will be focused on treatment. I'd also like to just bring out a disclaimer and just put this in front of everybody that we have to keep in mind that every treatment that we currently use for AIP or IgG4 related disease is being used off-label, whether this is through the FDA or the European equivalent, and this includes prednisone. Okay, so we have to keep this in mind. All right, so I've been given the question to try to answer in 15 minutes, which shrunk to 13 minutes before I started, of when to use non-steroid therapies specifically for type 1 autoimmune pancreatitis. And to kind of lay the groundwork to try to answer that question, I have to remind us that there's two phases of treatment for this disease. The first is induction of remission, and the second is maintenance of remission. And in my talk, when I'm referring to non-steroid therapies, I'll be talking about biologic therapies, specifically rituximab, as well as the steroid-sparing immunomodulators. So the short answer to the question of when to use non-steroid therapies is complicated. There are many different things that we have to weigh in general, and then also for individual patients. As it relates to general things related to treatment efficacy, we have to keep in mind that to date, the vast majority of the data are observational in nature. When we do have trials, they're generally small and often not with the controls that we're really most interested in. There are potential harms of treatment, which I'll touch on momentarily, related to side effects, but also financial costs. And in situations where maintenance therapy is not recommended, we also have to keep in mind that there are also risk of harms related to the progression of disease. At an individual level, there are many patient factors. Again, we'll come back and touch on some of these. And then also we have to realize and remember that there are many different provider factors related to our unique training programs, which guides to our subspecialties, as well as our familiarity with the disease, as well as the various treatment options. And so you can think of many, many different combinations, and it's really not possible to try to touch on all of those today. So what I'd like to do is to try to reframe the question, and I apologize to those who are English majors to use a double negative, but the question I'd like to frame this as is when to not use non-steroid therapies. Okay, I do think there are some principles that can be conveyed with high confidence that I think is really important as we're starting to think about this new era of therapy. So the first principle that I'd like to put in front of you is that non-steroid therapies should not be used for steroid non-responsive disease. Now I realize this is a triple negative here, which is not a shame on me, but so to figuratively depict this and to add on to what Dr. Chari was sharing. So a common curbside question is, I have this patient with autoimmune pancreatitis. This is presumably type 1 autoimmune pancreatitis. Put them on high-dose steroids or have them on azathioprine, and they're just not responding. Should I escalate to biologic therapy? And my first question, and what I put in front of you, is that really the thing that we should primarily be asking ourselves is not what is the treatment, but is this correct diagnosis? And Dr. Chari went into detail related to the differential diagnosis, but I'll sort of add to that by sharing that I think there are two reasons why this is a principle that we can all stand on. The first is that induction of type 1 autoimmune pancreatitis with steroids occurs very rapidly. Okay, Yan B published data from Mayo Clinic and showed that in patients who presented with type 1 autoimmune pancreatitis with a in which a confident diagnosis could be established. Even when biliary stenting was not used, the liver biochemistries improved rapidly by about 50% within the first 1 week. So this is a very, very quick response. The second is that imaging appearance of the pancreas also improves quickly. This was shown and described originally by Moon and colleagues, where they show that even within 2 weeks, you can see significant radiographic response. Again, these are two objective measures of response. I'm not talking about symptom response, as Dr. Chari laid out. There are many reasons that patients may feel better when they're on steroids. The second thing, though, is that induction with steroids is highly effective. And in studies that have been published looking at European multi-center data, multinational data, as well as in the original Japanese multi-center data, the remission rates are very, very high, both at initial presentation as well as when treating disease relapse. And these are the pictures that we love to look at, where there's improvement and normalization of the pancreatic enlargement, and also normalized enhancement of the gland. Now, unfortunately, and again, Dr. Chari laid the groundwork for this, that we've all seen at least one of these patients where unfortunately there's something that led to an anchoring of a diagnosis of type 1 autoimmune pancreatitis, in this case, a patient with a relatively high serum IgG4 level, but as you can see, unfortunately, while on steroid therapy did not respond, and actually had evident cancer. So again, so a reminder here is that in patients who are not responding to steroids, we all have to consider an alternative diagnosis, not should we be starting the patient on a new treatment. The second thing that I'd put out is that non-steroid therapy should not be used in patients with type 2 autoimmune pancreatitis. And I'm not going to go into all the details of subtyping, but keeping in mind that when the two subtypes are defined by their histopathology, there are some trends that we see as it relates to the demography of the patients, as well as the distribution of the disease. And importantly, as it relates to the clinical course, patients with type 2 autoimmune pancreatitis have a very low risk for disease relapse. And so whether it's non-steroid therapies, or I would even put forward maintenance corticosteroids, generally are not necessary for management of this disease subtype. Next, non-steroid therapy should not be used when toxicity monitoring is not feasible. So we have to keep in mind that with all of these treatments, that dose-limiting toxicities are common and or potentially severe with non-steroid therapies. And I like the way John Stone refers to this, is that these things are not candy. And we generally think of these as treatments to try to avoid corticosteroid-related toxicity. But remember, these are not benign medications. So there's wide data and extensive literature related to these drugs, but specifically in patients with type 1 autoimmune pancreatitis or IgG4-related disease, the thiopurines, it's up to 20% of patients who have to have treatment interrupted. Fortunately, most of the time, this is relatively benign issues of symptoms or transaminitis. In patients with rituximab, and the most recent meta-analysis, it was about 25% of patients had some type of an adverse event. Again, fortunately, most of the time, these are relatively mild issues with infusion reactions, generally being transient and self-limited is the most common. And then less commonly, but certainly severe, are the situation where patients can develop persistent hypogammaglobulinemia or reactivation of chronic infections. And again, we have to keep in mind that all these drugs have various drug-drug interactions. So I think, before we're even entertaining pulling the trigger on any of these medications, it's important that we're familiar with the safety profile, the drug monitoring. That's one part. And then the second part is that we have to have a patient who's able to comply with routine monitoring. All right, and then the last principle that I'd like to put out is that non-steroid therapy should not be used when the expected benefits are small. And this is a motherhood statement, in that we don't want to recommend any intervention when the probability of harms outweigh the probability of benefits. But to specifically, apply this to type 1 autoimmune pancreatitis, the three scenarios that I think of are: first, when there's a low risk for disease relapse; the second, if the anticipated relapse-related morbidity is low; and then lastly, if the residual disease that we're seeing, again, this is generally on imaging, is primarily fibrotic. Now, I put an asterisk next to the word expected because I'll be the first to acknowledge that we're not good at any of these. So there are a number of risk factors that have been identified, but we cannot completely predict this for each individual patient. Second is that we have to keep in mind that when patients do develop disease relapses, these can be metachronous involving different and new organ systems. And then lastly, and I think Dr. Chari had a presentation or case of this too, this is an extreme one here that I've seen in clinic, is that with current standard of care imaging, we don't really have a great way to tease out inflammation versus fibrosis. This is a patient with diffusely enlarged body, or not diffusely, focally enlarged body and tail, markedly elevated serum IgG4, EUS-FNA was negative, but did not respond to steroids, and we were concerned for malignancy. So she underwent resection with a distal pancreatectomy. You can see on the gross, this is the most dramatic one I've seen, this thick fibrotic ring, and the histopathologic features were classic for type 1 autoimmune pancreatitis. So we're not good at this. All right, so let me try to twist it, and in the last couple minutes here, try to answer the question that was really put in front of me. And the question is, when should we be considering these non-steroid therapies? I think there's two situations where we can definitely do this. The first is in situations where there's the inability to tolerate high-dose corticosteroids for induction therapy. I'm not sure if there's any birders in the room, but this is the nene, the Hawaiian state bird, or the Hawaiian goose. This is the rarest goose in the world, is my understanding. At one point, it was near extinction, but apparently they breed well in captivity, so they're doing okay today. There's none near the resort. If you're looking, you have to go to the park. That's a tangent, but it's just to remind me that this should be a rare situation. Okay, this is not a patient with a little bit of diabetes, and you try to make a case of they can't tolerate high dose prednisone. There's data coming out of Europe that I don't think has really penetrated that well in the United States, that patients can be successfully achieve disease remission with doses as low as 20 milligrams of prednisone. So again, however, if patients are not even able to tolerate that, then yes, we have to move on. The second would be the quote unquote high risk situations where there's one or more of the following risk factors for disease relapse. And obviously, if there's a prior disease relapse, that gets you there. These include multi-organ involvement, particularly if the proximal biliary tree is involved. Elevated serum IgG4, and this is particularly if it remains 2 times the upper limit of normal after high-dose corticosteroid therapy. Imaging features, and then also there's some newer literature related to elevated serum IgE levels. And these recommendations are consistent with the most recent version of the international treatment guidelines that Dr. Okazaki led along with Dr. Chari. So, unfortunately, though, we still have a lot of unanswered questions. Dr. Hernandez is going to present some new and exciting trial data from the Mitigate trial that was recently published. But even with those results, I think there's still a number of questions related to, do these drugs actually change the natural history? In other words, can we prevent organ damage? Can we prevent fibrosis? These are questions that are important to instruct us. IBD went through this decades ago, this sort of paradigm shift of step-up approach to step-down therapy. I don't think we have the data to guide us in that direction, but again, there's a need to really think about and add the study program, the sequence of trials that will be needed to answer that. And then also an important voice in this is at an individual patient level, how do we assess their preferences related to the trade-offs of costs, drug administration, potential risk for side effects, potential stakes related to disease progression or incompleted disease. So in summary, non-steroid therapies are used to treat type 1 autoimmune pancreatitis, but unfortunately there's a scarcity of high quality data. I think it's important to recognize a situation where non-steroid therapies should be avoided. So in other words, those are the off limits, no-nos. But when those exclusion criteria are not met, I think it still is something that we need to carefully consider, particularly for the difficult to control patient. And I'd also just like to, again, come back and just reiterate that I think it's important for all of us that when we're thinking about treating these patients, that we should adopt the mindset that the medical oncologists have, that the best care that these patients receive is when they're being treated within the context of a clinical trial. And if that's not available, including to refer patients to clinical trials, that it's done in the context of some type of a prospective disease registry so that we can continue to advance the field. So lastly, just plug for the state of Hawaii, I suppose. If folks are still not adjusted to the time change and up at 4 a.m., I highly encourage you to make the trek out to Haleakala National Park to watch the sunrise. They say a picture's worth 1,000 words, but this is a really insufficient picture to show how awe-inspiring that was. I'd like to acknowledge the team at Ohio State, as well as all of the folks who shepherded me in the early days at Mayo Clinic, including Dr. Chari, and then also not listed here, but a number of Japanese investigators who have really shepherded and coached me along the way, including Professor Okazaki and Kamasawa, who I don't believe is here. And then lastly, just again, final plug for the IAP. If you haven't seen this slide, then you've been at the beach too much, but all right. Thanks.
Thank you, Phil. So last but not the least, I'd like to invite Dr. Yasmin Hernandez-Barco for this talk. She is a medical pancreatologist at the Department of Gastroenterology, Mass Gen Hospital. And today she's going to speak about biologic therapies of autoimmune pancreatitis.
Thank you so much to the course organizers for this invitation. It is really an honor to be at this session speaking with 4 individuals that have contributed so much to this field. And so today I was asked to talk about biologic therapy of autoimmune pancreatitis. I do have some disclosures, and as Dr. Hart said, this talk is going to include a lot of off-label medication use and drugs that are under study. But I still think it's very exciting. It kind of looks like an IBD talk with all the new medications that are possible. So we'll see where the field goes. So I'll go through the various clinical subtypes, talk about the pathophysiology of IgG4 related disease, and then some management strategies on the horizon. So type 1 and type 2 autoimmune pancreatitis are 2 distinct diseases, as we know. And I think one of the major features is that type 1 typically has a pretty high relapse rate compared to that of type 2. Type 1 autoimmune pancreatitis is the pancreatic manifestation of IgG4 related disease. And it's important, I think, not only for therapies, but really to find biomarkers for earlier diagnosis, because at this time, the majority of patients do present with irreversible organ damage. The classic histopathology in type 1 autoimmune pancreatitis shows the lymphoplasmacytic infiltrate, which is really rich in these B cells and T cells, which drive the pathophysiology of the disease. And then in type 2 autoimmune pancreatitis, I'll mention it only briefly, because again, it is so steroid responsive, but the histology shows that it's a different pathophysiology, that these patients will have a lot of neutrophils infiltrating their pancreas, and you'll have the classic gel lesions. And again, these patients are very steroid responsive, and if they don't respond to therapy, then it is important to consider another diagnosis. So back to type 1 autoimmune pancreatitis. As Dr. Hart mentioned, there's kind of 2 strategies to the way that we treat patients. One is we want to induce remission, and then the second is we want to maintain remission. And the indication for treatment, essentially almost all patients with pancreatic involvement, those with a persistent pancreatic mass, biliary involvement, or cholestasis, those are indications for treatment. But again, we didn't coordinate this slide, but as Dr. Hart mentioned, whenever you select a therapy, there are a lot of factors that you need to consider. One are patient characteristics. Briefly talked about, patient's age, their comorbidities, their preference, cost, where you are in the world with this disease and the practice patterns. And then what are the disease characteristics? Is this somebody with pancreas isolated disease, or do they have multi-organ involvement? Do they have very high risk for relapse, or have they already had a relapse? And then the efficacy, again, are you trying to induce remission, or is this maintenance therapy because the patient has a high risk, or have they already relapsed? And then what about the safety profile of the different medications? For the most part, they all have some kind of infectious complications, but then we worry about toxicities with immunomodulators, infusion reactions with things like rituximab. And so taking all of this into consideration when making a decision, I think is important, especially now as we move forward with new medication options. I do want to mention that steroids have good data that was done by our Japanese colleagues, and there was a randomized clinical trial that of course showed that individuals that were treated with induction therapy and long-term maintenance when compared to those just treated with induction therapy, those that were treated with maintenance therapy did quite well and their relapse rate was much lower. And in this study, they did not really see the toxicities that we sometimes worry about, diabetes. And so it's a very reasonable maintenance therapy. But why not steroids? Again, even though it's incredibly effective at inducing remission, at 1 year you have about 50% relapse rate, and up to 3 years it can be as high as 75. And then those patients that are highest risk for relapse, you may not want to use steroids potentially upfront, but especially if they have their initial relapse, if they have multi-organ involvement, you're going to watch them carefully because you may want to consider something that's not steroid treatment. And then again, it wasn't shown in the Japanese studies, but we at least anecdotally see much more metabolic bone disease and diabetes in our patients. And so in somebody that we think we're going to have to give steroids to over and over again, we sometimes will think of other options. Briefly about immunotherapy, because Dr. Hart also covered it. The relapse rate is lower, but one of the challenges is that it's very difficult to predict which patient is going to respond to which medication. If they have a great response, I think that's wonderful. But if they don't, and you're trying and they have, their bile ducts involved, it can be challenging. And there's, of course, frequent monitoring that's required, which can be a burden for patients. So now I'll move into the biologic section of this talk. So I always start to talk about B cells. And so B cell differentiation, essentially B cells start in the bone marrow. They first acquire CD19 expression on their cell surface. Later in their lifespan, they'll acquire CD20 expression. And then as they move on through the periphery, they'll lose CD20 expression. And later after that, we'll lose CD19 expression. And this is important because you'll see some of the medications are targeting CD20 and CD19, and so you have a larger proportion of B cells that actually express CD19 on their cell surface. Plasmablasts, which are a subtype of B cells, accumulate in the blood of type 1 autoimmune pancreatitis patients compared to healthy controls. And also plasmablast expansion is associated with organ involvement. And as you can see on the right-hand side, that plasmablast expansion actually contracts after steroid treatment. And so these cells are involved, of course, in the pathophysiology of the disease. So here in this slide, I'm going to present what we believe is a pretty comprehensive understanding of the pathophysiology of IgG4-related disease. The two major cells that are involved are those of the B cell lineage and those of the T cell lineage. And we have CD19 expressing plasmablasts or B cells presenting antigen to a very specific CD4 cytotoxic T cell. These two cells interact through a cell surface marker called SLAMF7, and it's these T cells that are actually secreting cytokines and chemokines that are driving the fibrosis of the disease. And the expansion of the B and T cells are what are giving you these mass-like or an organ enlargement that is so classic of IgG4-related disorder. So the first therapy that I'll discuss is rituximab. Rituximab is an anti-CD20 medication. It's a chimeric monoclonal antibody that binds to CD20. It's a B cell depleter, so it decreases B cell in patients. And on the bottom, you'll see that some of the history here, Dr. Chari and many of the people in the room were really the first to observe that a patient was treated with rituximab because there was a lot of B cells in their biopsies, and the patient responded very well in multiple organs. Again, rituximab works here at the level of the B cell. It depletes all B cells. And again, the group at Mayo Clinic looked at rituximab in inducing remission in patients with IgG4 disease. And the remission was achieved in 98% of patients, which is essentially that of steroids. And what they looked at additionally is the induction group plus induction and maintenance. And what they found is that those patients that were treated with rituximab maintenance therapy, they actually had a much lower relapse rate when they looked at them over the course of 3 years. As I mentioned earlier, rituximab does have adverse events. There are infusion reactions up to 20%. A lot of this is driven by the fact that it's a chimeric monoclonal antibody. The infectious complications are there, and considerations like vaccinations prior to treatment is very important. And so all this counseling for patients is something, again, you have some kind of experience before having the patient start this therapy. So the next medication I'll mention briefly is the rituximab biosimilars. Same mechanism of action, but sometimes from a financial perspective is a little bit more cost effective for patients, though I say cost effective very loosely. They're quite expensive medications. The next medication is enebelizumab. This is an anti-CD19 medication. It also is a B-cell depleting therapy. And they completed their phase 3 randomized double-blinded multi-center placebo-controlled study. Again, this is a humanized anti-CD19 monoclonal antibody, and it's a B-cell depleter. So it's depleting more of those B cells, and it is humanized. So it was very exciting as the trial was ongoing to see how this would pan out. And less than a month ago, the trial results were published in the New England Journal of Medicine. And what they found is that the medication actually reduced the risk of flare by 87%. So it was really quite effective. They looked at patients over the course of a year, and it did reduce the risk of flare compared to the placebo group, which was able to receive steroid therapy. And then we see, as predicted, that that the B cells decrease, as does the IgG4 level in the patients that were treated with the medication. And looking at the adverse events, almost everybody in the trial, both placebo and study drug, had some kind of at least mild adverse event. And the adverse events were slightly higher in the enebelizumab group. But the anaphylaxis was in a patient they described that was not pre-treated fully. And then the infusion reactions were not that different between the two groups. The next medication that I'll mention is obexelimab, which is now moving into not a full B-cell depleter, but it's a B-cell inhibitor. So this medication it's the Indigo trial. It's a phase 3 randomized double-blinded multi-center placebo-controlled trial. And this mechanism of action works by mimicking an antibody-antigen complex that binds to the Fc receptor and CD19. So it suppresses the B cells, but it's not a full depleting agent. I include here their phase 2 data, which shows that there were quite a few primary responders. One thing I want to mention is that there was only one patient in that study that had pancreatic involvement, but again, in the in the phase 3 trial, I'm sure they'll include more. And you can see here that's distinct from rituximab and enebelizumab is that the B cells go down to about 50%, not fully depleted, but it seems to be effective, but more data obviously will be coming. So the next medication, and I move that little arrow into the cell more, is rilzabrutinib. This is a tyrosine kinase inhibitor. Again, this is a B-cell inhibitor, not a B-cell depleter. And it works through various pathways of the innate immune response. This is in a phase 2 trial. And then again, they're looking at patients that achieve remission, steroid-free remission. The next medication is zanubrutinib. This is a medication that's currently only being studied for head and neck disease, but again, it's the same disease across all organs. And so potentially if they have positive results, this could be another treatment option. Again, this is also a tyrosine kinase inhibitor. And then I mentioned SLAMF7, and even though this trial did not have positive results, again, I think it's still very exciting to know that now we have such better understanding of the pathophysiology that we're able to develop treatments based on what we understand. And so this was elotuzumab, which is an anti-SLAMF7 medication that's approved for multiple myeloma. Unfortunately, the trial was terminated due to lack of efficacy, but again, I still think it's exciting that this is based on our understanding of the pathophysiology of the disease. And then the last medication that I'm going to mention is tofacitinib, which is a JAK inhibitor. And there's a study that showed that this was actually effective, especially in patients that had IgG4 sclerosing cholangitis. And so this is a single center, non-randomized, open label clinical trial comparing the JAK kinase inhibitor to cyclophosphamide. And then again, this medication works by decreasing cytokine production. So we'll see if perhaps it's actually decreasing the amount of damage that occurs in IgG4 related disease. This is a very brief slide sort of summarizing the treatment approach to autoimmune pancreatitis. I think with an initial treatment, steroids are very reasonable, especially in those individuals with pancreas isolated disease without evidence of other organ involvement, and of course that can tolerate steroids. Rituximab and probably inebilizumab for patients that are very high risk for relapse. This could be a very good first line option as well. That might have been very controversial. We can talk about it after, but I think there are patients that we think are going to be very high risk for relapse, and maybe these medications could be considered up front. And then we do have options for relapse. And again, those risk factors for relapse are the same ones that Dr. Hart reviewed, which is biliary involvement, multi-organ disease, very high IgG4 levels. And of course, a patient that has already had a relapse, you probably don't want to use steroids again unless there's a reason to not use one of the other medications. So in summary, relapse rate with steroid treatment alone is high. B cells and plasmablasts play an important pathological role in type 1 autoimmune pancreatitis. We can consider biologic therapy in those patients that have had a relapse and potentially those with high risk for relapse. And when choosing rituximab, maintenance therapy is probably important for most patients, though we don't have great data to tell us who really needs maintenance at one interval. And then I still think it's very exciting that we have so many medications that are under study for this disease. And we'll hopefully be an IBD lecture one of these days with all the new medications and treatments for all forms of pancreatitis. I'm at Mass General. I was very lucky to meet John Stone. When I Googled rituximab Mass General AIP, he came up. And so we've worked together now for about 5 years. They're a great team, and happy to take questions now during this session or by email.
Thank you to all the speakers for keeping time. So now we have about 10 minutes for question and answers, and I'll ask all the speakers to please come to the podium.
I have a comment. Santi Vege from Rochester. First of all, this is exquisite session. You know, listening to all of you, you have updated us so much. And as Suresh knows and Phil knows, we see a lot of patients with AIP, and I see a lot of patients with AIP. I want to make one comment. Late 90s, when Suresh was leading our group and I was seeing patients talking to him, there were people who used to come with vague abdominal pain. You do CT and they have the sausage pancreas before the criteria came, before he even came up with Izod. And you know, they're just not being treated with any steroid or anything at that time. And the vague symptoms continue, and you do a scan after 8 weeks, 10 weeks, and rapidly the whole thing used to become like a sliver. And that's when Suresh started. I don't know how many patients you have accumulated like that in the database. The reason I'm saying it is, till about 10 years ago, we used to manage AIP type 1 before the rheumatologists and everybody stepped in, changed the names, gave new criteria, so on and so forth. We used to see parotid, we used to see the lacrimal, we used to see the lung, kidney, retroperitoneal aortitis, and all those things. But the issue that's happening now is you have a sausage, you have intrapancreatic bile duct stricture, you treat with steroids. I sometimes treat with just 30 milligrams, like the 20 milligrams that you're talking from Europe. And we get about, you know, good response. And then if these people are seen elsewhere and they have some vague symptoms, and you do IgG4 regularly in addition to the CT, even if the CT shows complete sliver-like pancreas in 12 weeks of steroids, but if the IgG4 is, you know, about 200 or 250 or even 300, they all get rituximab now. Because for a rheumatologist to give rituximab is like an ERCP person saying, if you have one episode of idiopathic, I'll do pancreatic sphincterotomy, no big deal. But rituximab is rituximab. So I think this is the big thing that's happening. I strongly feel these people should still be under the control of pancreatologists. That's my first statement. And I don't know, you may have differences of opinion. You work with a very famous rheumatologist. And the second one is a very quick one. Fantastic data from Atsushi and team from Japan. But I'm thinking that, the pancreatic cancers within 2 years after your AIP, and particularly if you break them into 1 year, maybe just the cancers to start with. And 1 year is not uncommon for a pancreatic cancer to go on lingering and then so if you cut it down, suppose if you exclude them, would the risk be enough for you to do a surveillance? Those are the comments.
Yeah, so let's go for the first comment with regard to treatment of patients who have responded to steroids and they have, so basically they're in remission. What is the role of biologic agents like rituximab in these patients? We can go through the panel.
Well, I'm not going to answer that, but I was going to respond to the comment that all of these patients should primarily be treated by pancreatitis. I would disagree with that, and I think this is a multi-organ disease. And so it requires a multidisciplinary team. There's no, I mean, there may be institutional leads that may come from different specialties, but this is a team sort of approach. I had to skip over one of my slides, but one of the points I wanted to emphasize though was the importance of having with these patients having a very low threshold to refer to medicine and surgical subspecialists.
Primary pancreatologist, you consult the
well, yeah, I don't see that as being different from a rheumatologist being the first person to see them and then passing them on. In the same way that we would not feel comfortable with a rheumatologist working through the differential diagnosis of pancreatic enlargement, I would put forward that we probably shouldn't be the primary ones working through orbital disease unless it's just a very, very flagrant disease manifestation. That's just my 2 cents. I know where you fall on this bit.
No, because of where I am, but I think in general, I think a multidisciplinary approach for everything is just wonderful. I'm very blessed to be the only medical pancreatologist at Mass General, and so whether it's necrotizing pancreatitis, I'm working with the surgeons, interventional radiology. If it's IgG4, we're working with radiology or rheumatologists. I see your point, which is if a patient looks pretty good, but they're high risk for relapse, and somebody else that they may just want to treat with a biologic therapy forever and ever and put them on maintenance therapy. And perhaps having a medical pancreatologist say, oh, just with the IgG4, yeah. Yeah, and I think those are the patients that you really have to have discussions about, because what is the role of putting them on a biologic forever and ever? What are you preventing? And I think, I didn't include that in my talk again because of time, but you did, which is what is the role of therapy? Are we really preventing complications? Are we really preventing damage? We think so, but we'd have to detect earlier in a lot of patients, and when they have this end stage disease, maybe those are not the patients that should receive rituximab. And to your point, I had a woman that came to us from New Hampshire who was treated 7 rounds of 12 weeks of prednisone for an IgG4 at 200 for recurrent acute pancreatitis, and she had a small neuroendocrine tumor. So I agree about treating just an IgG4 level without being thoughtful about what's going on, but I do agree with multidisciplinary approach.
IgG4 level in my practice. If it is low risk, I just manage the patient.
So maybe do you want to comment? And
Sure.
Just go on to the next question.
There's another question, but is it on? So, I'm in a very unique situation where I'm the only pancreatologist in MD Anderson. It's a cancer center. We do not treat benign disease. So I'm in the middle of people who do not see benign disease. They cannot even read the pathology of autoimmune pancreatitis correctly. The radiologist doesn't recognize autoimmune pancreatitis in all its manifestations. So very unique, and I am working with rheumatologists in the community who don't know how to treat the disease. So it's a fascinating situation to be in, and I'm like, I don't have an endoscopist who can take me these biopsies we used to get at Mayo. So you're basically working with your clinical skills and whatever radiology you can read. I think that the community practice is way different from what we are living in this world, where the Ivy Tower world, where you have all the access to all the specialties and all the people who you're asking for help are the world leaders in the field. That's a very unique situation that's not going to exist in the community. So when you live with bare bones expertise around you, you do what you can, but I think that it's a multidisciplinary. I would not be comfortable if my patient said, I had a patient who had blurred vision. He's driving from Alabama to Florida. I've treated him for pancreatitis, but he says, I got blurred vision, I turn back and go home. I'm not going to treat that. It ended up being some kind of a orbital involvement by IG4 disease, but it's not my area of expertise. So I think it's clearly a multidisciplinary disease and you need experts in the field. But when you are in an area where everywhere around you, as somebody said, this is a what? IgG4 desert. There's nobody around who knows enough about the disease. You have to guide the other person in terms of what you think they should be looking for and get help as much as possible for the patient. As far as serologic relapse alone, I've never treated this from day one. I feel it's going to relapse serologically, and it should not be the only reason to treat the patient.
That's the question.
So, Dr. Takikawa, do you want to take the question with regard to pancreatic cancer diagnosed early after diagnosis of AIP in the first year in your cohort?
In our study, there were two cases diagnosed within first year, but one case is at the diagnosis of AIP, ERPP showed severe narrowing, so brushing cytology showed class 5, and one case showed after steroid treatment, pancreatic narrowing persisted. So ERCP repeated, and which led to diagnosis of malignant pancreatic cancer.
Yeah, thank you. Great session. I just wanted to ask, when we see, like in the pancreas, you see the fibrotic pancreas after treatment, the sclerosis that you see in other organs like nephrosclerosis and other sclerosis. And when you're trying to tease out relapse, like let's say you have tubular interstitial nephritis and the creatinine is going up, and trying to do that in a multi-system disease and these different end organs other than the pancreas, how are you approaching sort of recurrence or relapse versus sclerosis based on sort of that specific organ system?
So Rahul and I he shared a patient with me, so I know where he's coming from. So my own take on this is that if that whatever is not responding to steroid is not, it's either a fibrotic condition but it's not a relapse of IG4 disease. I think my way to figure out whether something is a fibrotic condition or is a relapse of the condition is to see if it improves on steroids. If it does, then I have to take up immunosuppression, because before that, I think going directly to a higher level of immunosuppression without knowing that what you're dealing with is a true relapse versus effective fibrosis is problematic. So.
Can I add to that? I think the three ways to sort that out would be, number one, if you have operative pathology, which is hopefully not the case. Number two is what Dr. Chari mentioned. And then number three is that this is, I was careful that I said there's no standard of care imaging for this, but there is some work that's being done to do sort of a dual PET imaging with FDG, and then also something called FAPI. And then you overlay, or you technically don't overlay them, you look at them side by side. If the FDG lights up, that's inflammation. If the FAPI lights up, that's fibrosis. So again, that's not widely available, but that's something hopefully in the works that can be useful.
We'll do one last quick question.
Reasonably quick. I'm a pediatrician, so I only treat type 2, but I was wondering how the biological drugs are actually chosen. In IBD, we repurpose from rheumatology or from psoriasis. And whether this is actually due to the companies actually supplying the drug, for instance, with tofacitinib, you might be better off having upadacitinib because it's once daily. They're all, I'm just not quite sure how the drugs are actually chosen for this.
Could you repeat the last part of the question? You're not sure how the drugs are?
How they're actually chosen. Are they actually repurposed from other diseases?
Oh, some yes. For example, inebilizumab was already approved for a different indication. The anti-SLAMF7 medication was already approved for multiple myeloma. So some of them have already are approved, and so they're just based on, I mean, I can't speak for the companies, but based on the biology, they are trying to repurpose it and actually get an FDA approval for this indication. So that's my best insight. I don't know if others have comment.
So that was a fabulous, fantastic session with lots of education and good discussion. So I close this session now, thanking all the speakers for the great talk.